Hi everyone, I'm Jennifer Walsh, Senior Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us this morning for a public briefing for the recently released report, Pain Management in the Opioid Epidemic, Balancing Societal and Individual Benefits and Risks of Prescription Opioid Use. You can now download a copy of the report and other supporting materials, including today's PowerPoint slides, at www.nationalacademies.org/opioid study. Again, that's nationalacademies.org/opioid study. And you can also follow the conversation about the report on Twitter at #NASEM opioid study. So for those of you not familiar with the National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. The National Academies, of which the former Institute of Medicine is part, operate under a congressional charter to the National Academy of Sciences that was signed by President Lincoln in 1863. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of tasks. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. So for today's briefing, we'll start off with opening remarks and a summary of the report, and with the remaining time, several members of the committee that wrote the report will answer some questions you have. Please note that this briefing is scheduled to last 1 hour unless we run out of questions beforehand. Lastly, I want to go over a few technical aspects of the webinar. After opening remarks, we will begin to take questions through the Q&A box located in the lower right-hand corner of your screen. Simply type your question in the box at any time and click Submit. We ask that you leave the box sent to Send Questions to All Panelists. And if you have any technical issues during the event, please contact WebEx at 866-229-3239. Again, that number is 866-229-3239. And with that, I'd like to turn it over to Dr. Victor J. Zhao, President of the National Academy of Medicine.
Well, thank you all for being here today. I'm Victor Zhao, the President of the National Academy of Medicine, and I'm very happy to welcome all of you to this public release of the report, Pain Management and Opioid Epidemic, Balancing Societal, Individual Benefits and Risk of Prescription Opioid Use. As you all know, and you heard from Jennifer Walsh, the academies have a long history of taking on challenging and contentious issues, and the report being released today is no exception. Our nation is experiencing an opioid epidemic, a major public health crisis that has crippled communities across the United States. As of 2015, 2 million Americans aged 12 years or older had a substance use disorder that involved prescription opioids, and more than 590,000 had a substance use disorder involving heroin and illicit opioid. Drug overdose, driven primarily by opioids, is now the leading cause of unintentional injury death in the United States, with more than 60% of overdose deaths in 2015 involved a prescription or illicit opioid. You know, about as many Americans are expected to die this year of drug overdoses as died in Vietnam, Iraq, Afghanistan wars all combined. It's a staggering number. A critical feature of the opioid crisis is that prescription and illicit opioid epidemics are intertwined. The increase in opioid-related deaths have occurred in tandem with an equally increase in prescription of opioid medications for purposes of pain management. Prescription opioids may be a gateway to illicit opioid use, and certainly a majority of opioid heroin users began with prescription opioids, although this is not the only pathway. In addition, regulatory efforts intended to reduce harms associated with prescription opioids, such as the development of abuse-deterrent formulations, may actually inadvertently contribute to increase in heroin use. So the risks of opioids are impossible to ignore. State and federal governments have taken action recently to address the opioid epidemic. State efforts range from development of prescription guidelines to establishing prescription drug monitoring programs to declaration of public health emergencies. At the federal level, Office of National Drug Control Policy and Health and Human Services have ramped up efforts to reduce opioid-related overdoses, deaths, and addiction. Certainly, the CDC issued a set of guidelines for prescribing opioids to adults with chronic pain in 2016. Now, the FDA has also taken forceful action to address this challenge. Among FDA's response was the launch of an opioid action plan in early 2016, describing action it would take in its role as federal agency responsible for protecting the public's health by ensuring efficacy and safety of drugs in the United States. And most recently, Dr. Scott Gottlieb, the new commissioner, has demanded successfully that a pharmaceutical company to take its opioid product, Opana ER, with properties for high abuse off the market. So as you can surmise, FDA has an important role in preventing the opioid epidemic. While the epidemic is a complex issue with multiple contributing factors, it is impossible to address the epidemic without addressing the process for approval and monitoring of these drugs. Indeed, opioids present unique challenges. They certainly have significant clinical benefits when used as prescribed, but yet they can cause harm when misused. The committee notes, and I quote, "The ongoing opioid crisis lies at the intersection of two substantial public health challenges, reducing the burden of suffering from pain and containing the rising toll of harms that can rise from use of opioid medications," end of quote. So regulators and policymakers face a difficult challenge in balancing access to appropriate medication with their risk. So one component of the FDA's opioid action plan is to reassess agencies' risk-benefit approval framework for opioid approval and monitoring. As a consequence of this, the FDA commissioned this study specifically informed this reassessment. And the task was embedded in a very broad range. But specifically, the committee was asked to provide an update on state of science of pain research, care, and education since the publication of 2011 IOM report, Relieving Pain in America. The committee was asked to identify regulatory actions the FDA can take to address opioid epidemic with a focus on its development of a regulatory framework for incorporating broader public health impacts of opioids into agencies' future opioid approval decisions. The committee was also asked to outline steps that can be taken by other stakeholders, prescribers, professional societies, federal, state, and local government agencies. And in addition, the committee was charged to identify important research questions to be addressed to assist the FDA with development of its regulatory framework. To carry out this task, the National Academies convened an 18-member committee in spring 2016. This committee drew from experts, a diverse group with expertise in pain management, basic pain research, epidemiology, medical anthropology, substance use disorder, nursing law, drug development, public health, policy modeling, and decision science. So you can see there's an expert group with tremendous expertise. The committee was ably chaired by Dr. Richard Bonney, and we're very grateful for his leadership. And is joined today by other members, David Clark, Tracy Green, Erin Kesselheim, and Mark Schumacher. The committee dedicated over a year to examine this very important topic. They're supported by a very dedicated staff, and I'm going to read these names, which shows you how many people put a lot of time into this activity. Morgan Ford, who's a study director, Jonathan Phillips, and Claiborne, Tess Trout, Pamela Reese, Delma Cox, Daniel Flynn, Hilary Bragg, Christy Bell, and Andrew Hope. So you will hear the recommendation of the committee, so I would like to certainly turn this over to the committee chair, Richard Bonney, to tell you about the findings. I would say that I'm confident that the committee's work will have a great impact in helping the nation tackle this challenge. So over to you, Richard. Thank you so much, and the other 4 committee members for being here and doing a great job.
Thank you very much, Victor. It's our pleasure to make a public release of this report. I want to begin by thanking all the, not only the staff members that Victor just mentioned, but the members of the committee. I am a great fan of the National Academy's process, and it's just amazing to reflect on the amount of expertise that was represented by the committee members, tremendous talents, and truly dedication to this effort. Before turning it over to the committee members to talk about our findings, I'll just say a couple of words here about the approach that was taken to carrying out the task. First of all, of course, the committee reviewed the scientific literature pertaining to all the many questions in the charge, which ranged widely, as Dr. Zhao just mentioned. We also had 2 public workshops to hear from researchers and representatives from various stakeholder groups and agencies. The first focused on updating the science on pain management and the epidemiology of the opioid problem. There is a published proceedings of that workshop that is available also. We also did a second workshop focusing on the regulatory aspects of the charge, including how the FDA might systematically incorporate public health considerations into its regulatory framework. Final observation I'll make before turning this over to Dave Clark is that as Victor's opening remarks indicated, the prescription opioid epidemic is intertwined, and increasingly so, with epidemic of use and opioid use disorder arising out of the use of illicit drugs. An important theme in the report is that even in the regulation of the prescription opioids, that all regulators, and particularly, of course, the FDA, have to take into account the overall interconnected opioid ecosystem, including the channels by which drugs are diverted from the lawful channels to unlawful channels, and the transitions that users who become dependent on opioids, having begun taking them as prescribed, the transitions to the illicit drug market. So this will be a recurring theme in some of the observations that we now will hear. First, we'll talk about pain management and the progress and future directions in research on pain and opioid use disorder, and pass the baton to Dr. Clark.
Thank you very much, Richard. This is David Clark. I'm professor of anesthesia at Stanford University and director of the Palo Alto VA's Medical Center, and I'll take a moment to describe the role of opioids in pain management and some of our research priorities. First, to stress, the committee sought balance in their recommendations concerning opioids. Opioids have an undisputed role in the management of pain of particular types, specifically pain due to advancing cancers, for patients in end-of-life situations, and for people with severe injuries. Much less well established is the role of these drugs in the management of pain for patients with chronic pain conditions such as osteoarthritis and low back pain. And in fact, there is at least some evidence suggesting that the medications do not work as well as expected, and that outcomes, in fact, might be worsened. Moreover, there's a clear association between the long-term use of these medicines and the dose of the medications used and the likelihood of developing an opiate use disorder, as well as experiencing overdose or even death. We want to stress that there are alternatives to the use of opioids for the management of chronic pain. Some of them are listed on this slide. There are other pharmacological agents that can be used. There are psychological and behavioral measures that have been suggested and implemented. Rehabilitative strategies such as physical therapy and exercise are often emphasized in the treatment of these patients. Interventional procedures, including injections and the implantation of devices, has a role in the management of some patients with chronic pain, as does complementary medicine, yoga, acupuncture, and like techniques. Finally, I'd like to mention the gold standard multidisciplinary rehabilitation programs, which, though not well funded, often report very favorable results. So while each of these alternatives has its own sets of risks and benefits, often the risk profile is superior for these alternatives, although it must be mentioned that the same lack of long-term outcome data generally pertains to these alternatives as to opioids. What we specifically lack comparative effectiveness of long-term outcome data for these types of studies. Another task of the committee was to review advances made since the 2011 IOM report, and in fact, there have been many research publications that have come out related to basic and clinical aspects of pain. There have been advances in preclinical research as well as translational research, and there's been a movement in recognition that we need more pragmatic and practice-based trials that emphasize the investigation of alternatives under real-world conditions, and a growing recognition that the principles of precision medicine might lead us to a better application of the treatments that we have. However, we also recognize that the options practically available to a caregiver entering an exam room here in 2017 are really very similar to those that were available in 2011. So we have not made as much progress as we might have hoped in the overall treatment of pain. We have a specific lack of knowledge of how pain and opiate use disorder interact. That is, why a patient in pain might be more or less at risk for the development of an opiate use disorder when exposed to either illicit or prescription medications. This leads us to one of our first recommendations, which is invest in research to better understand pain and opiate use disorder. We want to emphasize that we need to improve our understanding of the neurobiology of pain. Hopefully that will provide a foundation for the development of non-opioid treatments. We need to emphasize investigations which would help us to understand furthermore the interaction of opioid use disorder and the treatment of pain, including vulnerabilities and factors which might be mitigated by clinical measures. So with that, I believe I'm going to turn over the baton here to Dr. Green.
Thank you very much. My name is Tracy Green. I'm an epidemiologist and an associate professor of emergency medicine at Boston University and the Warren Albert School of Medicine at Brown University, and I lead the Injury Prevention Center at Boston Medical Center as Deputy Director. Today I'm going to talk a little bit more about the committee's findings and recommendations related to trends in opioid use and harm. The committee found that the level and type of risk to a patient from opioid medications can be influenced by several factors. These include specific features of the opioid medications themselves, such as the compound, formulation, as well as how they are administered. But across the data, we found that opioids as prescribed, whether on an as-needed basis or at higher doses or higher morphine milligram equivalent doses, increase the risk of overdose and addiction. Indeed, there's a dose-response fashion to the data with increasing morphine milligram equivalent doses, leading to greater risk. There were 3 populations with unique risks in the context of the opioid epidemic that the committee focused on, and those are discussed in the committee's report. In the interest of time, we'll focus on the first one. However, the report goes into greater depth about vulnerable populations that include pregnant women and neonates, people involved with the criminal justice system, and people who inject drugs. So, addressing the public health aspects of prescribing is inherent in the consideration of opioid use in pregnant women, where clinical outcomes move beyond solely the patient to consider risks and benefits following exposure on the health of another. Neonatal abstinence syndrome, which is a group of conditions that may occur in newborns who are exposed to opioids while in the womb, is something that the committee felt important to address and goes into great depth addressing. The proportion of babies that are born with neonatal abstinence syndrome, or NAS, in the United States has increased in recent years, concurrent with significant increases in opioid use and misuse among women of childbearing age and subsequently pregnant women. Some jurisdictions have laws that criminalize mothers of babies born with NAS. The committee believes that more effective approaches would be to improve maternal and neonatal abstinence syndrome outcomes can be achieved by earlier identification and provision of supports for pregnant women using opioids, whether the use results from taking opioid medications prescribed or due to opioid misuse. Indeed, the approaches to improve those outcomes can be better refined by exploring further how the exposure occurred through research, and approaches that are clinically appropriate would include tapering off the opioid, sustaining the opioid, and managing and minimizing neonatal abstinence syndrome conditions and symptoms, as well as for pregnant women with opioid use disorder, initiation of medication for addiction treatment, or MAT, with the accompanying management and minimization of neonatal abstinence syndrome symptoms. And then for those women who are continuing on opioid use disorder medications, to maintain their care and minimize and manage their NAS symptoms. As Richard and Dr. Zhao alluded to in their remarks, another important finding that has important implications for the FDA and other organizations that develop interventions to respond to the opioid epidemic is that the prescription and illicit opioid epidemics are inextricably linked. Several studies have shown that many individuals who use heroin report their opioid misuse or opioid use disorder began with prescription opioid misuse. And the figure that you see there comes from national survey data from the National Survey for Drug Use and Health, reflecting that 4 out of 5 heroin initiates had a history of prescription opioid misuse. Those data continue to be confirmed through cohort studies and state-based data. So thinking through and further the declining price of heroin and regulatory efforts that are designed to restrict access to prescription opioids or reduce harms associated with them, such as abuse-deterrent formulations. These are medications with properties that make them difficult to abuse. That these approaches may contribute to increased use of heroin or other illicit opioids. The committee explored the abuse-deterrent formulation approach, and reflecting on the information that you heard earlier from Dr. Clark and the information that we have here on the intertwined nature of prescription and illicit opioid use, the reliance on ADS may undermine a successful public health response to the opioid epidemic. That abuse-deterrent formulations have the potential for benefit, but this is counterbalanced by recent examples of unexpected harm. Ongoing studies will help clarify the optimal role for ADS as a strategy for reducing misuse of prescription opioids. At this time, the committee advises caution. This reflection of the report led us to recommendation 4.1 here, to consider actively the potential effects on illicit markets or of policies and programs directed at prescription opioids, and to do so at the design and implementation point of those programs, those pertaining to prescribing of, access to, and use of prescription opioids by the FDA and other agencies within the U.S. Department of Health and Human Services, as well as state agencies and other stakeholders, and considering the potential effects of those interventions on illicit markets. Because they are intertwined and we can see that going into our efforts, we may have the opportunity to take appropriate steps to mitigate those effects. The committee also found a number of gaps in the data available to accurately describe the epidemiology of pain, opioid use disorder, and other opioid-related harms in the United States, including how pain and opioid use disorder relate to one another and how often they occur. The absence of publicly available data pertaining to surveillance, especially during the rise of non-medical use of prescription opioids, contributed to the epidemic and continues to impair national responses. To address those nuances of the evolving prescribed, illicit, and illicitly manufactured synthetic use trends, multiple, more sophisticated, and more responsive designs are warranted. Closing these data gaps would improve understanding of pain, opioid use disorder, and the overlapping prescription and illicit opioid use problems, and enable more effective and measurable policy interventions. That reflection led us to recommendations 4-2 and 4-3, involving improving the reporting of data on pain and opioid use disorder through the Substance Abuse and Mental Health Services Administration, the FDA, and the NIH, as well as CDC, to collaborate and identify those best practices to improve portray the epidemiology of pain and opioid use disorder accurately, objectively, and in relation to one another. And the second recommendation here on the screen, to invest in data and research to better characterize the opioid epidemic, considering its very rapid change. We need to be able to understand and adequately measure so that we can understand how to best address prescription opioid use, non-medical use, heroin, and illicitly manufactured fentanyl trends. And that, I will hand it over to my colleague, Mark Schumacher.
Good afternoon. It's Mark Schumacher, and I'm a professor of anesthesia at the University of California, San Francisco, where I'm also chief of the Division of Pain Medicine. It's my pleasure to present the committee's resolve around evidence on strategies for addressing the opioid epidemic. A constellation of policies and interventions and tools are available to reduce opioid-related harms, while also meeting the needs of patients with pain. And just briefly, these strategies that were outlined by the committee include influencing prescribing practices, an effort on public education regarding safe pain management, efforts around opioid use disorder treatment, ways to reduce harm, and of course, prevent fatal overdoses, as well as regulating lawful access to the opioid products. Influencing prescribing practices really represents a culture change in the practice of medicine. And just to remind us all, the relief of pain represents one of the primary responsibilities of the practice of medicine. And pain is one of the principal reasons people often seek medical care. However, at the heart of the committee's work is the sobering fact that the majority of deaths attributed to opioids are initiated through a prescription of an opioid analgesic medication, perhaps originally intended to relieve pain and suffering. Clearly, a single-minded treatment of chronic pain only with opioids is simply one more day of acute pain, has not provided the desired long-term pain relief or improved quality of life. Rather, such practices have been associated with great harm. Unfortunately, current efforts to improve pain education and knowledge about prescription opioid misuse and opioid use disorder among prescribers are inadequate and under-resourced. If education efforts around pain and analgesia are not substantially improved and resourced across all healthcare disciplines, especially medicine, the committee is concerned that it will undermine other efforts to reverse the opioid epidemic. Comprehensive pain education is needed for healthcare workers that goes far beyond the current average of a few hours that undergraduate medical education currently dedicates toward pain management or analgesic pharmacology. We are aware that there have been guidelines that have been released, certainly recently by the CDC, as well as efforts by the FDA. And we believe foundationally education and further education for healthcare workers are required to be able to apply and interpret these guidelines effectively. Moreover, they're going to be clearly important for developing competencies in the management of chronic pain. This work then led to the recommendation of 5-2 to establish comprehensive pain education materials and curriculum for healthcare providers. We believe that state medical schools and other health professional schools should coordinate with their state licensing boards for health professionals. That includes physicians, nurses, dentists, pharmacists, as well as outside sources of evidence-based medicine, including the NIH, Pain Consortium, the FDA, the CDC, and the DEA, to develop an evidence-based national approach to pain education through the state level. Another area that we believe is impactful for strategies involves the role of reimbursement of comprehensive pain management. Insurance-based policies have substantial potential to improve the overall well-being and function of persons suffering chronic painful conditions. However, they also have the potential to restrict the use of specific therapies such as opioids, as well as non-pharmacologic treatments of pain some that have been outlined before, including behavioral, mental health, and rehab, for example. Current reimbursement systems appear to have been misaligned and have misaligned incentives, effectively limiting behavioral, mental health, and other non-opioid approaches to pain management. The judicious deployment of insurer policies related to opioid prescribing would benefit from a commensurate increase in coverage and access to comprehensive pain management. Thus, we have a recommendation of 5-3 to facilitate reimbursement for comprehensive pain management. It is the committee's view that unless there's a vastly improved patient access to non-opioid strategies in the treatment of chronic pain, efforts to enhance provider and public education alone will be insufficient. Prescription drug monitoring programs is another tool to help address the opioid epidemic by enabling prescribers and other stakeholders to track controlled substances prescribing and dispensing information. These systems are typically administered at the state level. These drug monitoring programs, therefore, serve as an important tool for improving public health and safety. They can provide a direct way, in fact, that prescribers can educate their patients, as well as oversight organizations can understand how to reduce harm for the public good. However, from the committee's work, state laws differ widely with respect to access to this data and the requirements for use. These tools are therefore not being used to their full potential, as mental health and substance use disorder professionals may be excluded from their access. Patient and public education. The committee was struck by the relative lack of attention to the impact of educating the general public, representing potentially all patients, about the comparative effectiveness of non-opioid analgesics and non-pharmacologic pain interventions compared with the risks and benefits of opioid therapy. Just as important as investing in provider education and realigning payer policies, the committee strongly supports a national effort to educate the public about treatment and the management of chronic pain, the comparative effectiveness of non-opioid analgesics and non-pharmacologic pain therapies. Efforts to provide such public education should become accompanied by a change in patient and family expectations with respect to the treatment and management of chronic pain. In part, this should encourage patients to question their providers, for example, why they might need a particular medication. This has come to then a recommendation of 5-5 that I'll paraphrase. The nation's public health leadership and heads of major foundations and professional organizations should convene a body of experts in communication, pain, and opioid use disorder to evaluate an education program designed to raise awareness among patients and the general public about the risks and benefits of prescription opioids and to promote safe and effective pain management. With this, I believe I'll turn it back over to Tracy.
Thank you. I'm going to speak about the use of medications and treatment as a strategy that was reviewed by the committee. In the committee's view, it's ethically imperative to balance strategies for reducing lawful access to opioids with an investment in treatment for the millions of individuals who already have opioid use disorder. The use of medications and treatment with FDA-approved medications such as methadone, buprenorphine, and naltrexone is the standard of care for opioid use disorder, even for special populations such as pregnant and postpartum women. Medications are central to the treatment of opioid use disorder, and the committee acknowledges the central, if not exclusive, role in the treatment of opioid use disorder, as supported by the scientific literature. Although several efficacious medications for opioid use disorder are available, they are underutilized because of a range of factors. The committee recommends, then, to improve access to expand treatment, for opioid use disorder, for states to do so with support from federal agencies, and to expand treatment to evidence-based treatment to populations and in a variety of settings, including hospitals, criminal justice settings, and substance use treatment programs. Similarly, and similar to the effort in educating our health professionals in pain, would be to improve education in the treatment of opioid use disorder for healthcare providers, and a recommendation to remove barriers to coverage of approved medications for the treatment of opioid use disorder. Moving to other efforts, the committee explored harm reduction interventions to address opioid use disorder and overdose. Life-saving medication for treating overdose is available. Provision of naloxone to overdose victims by laypersons or health professionals in the pre-hospital setting is the standard of care, and community-based programs and other first responder agencies have adopted this protocol for treating opioid overdose as a harm reduction approach. The committee's recommendations convey the insistence upon low-cost, ready access to naloxone, as well as unfettered access to sterile syringe equipment to reduce harm. The recommendation of 5.9 would be to leverage prescribers and pharmacists to help address opioid use disorder and overdose. To do so, to expand access to naloxone through prescriber and pharmacy-based approaches. Recommendation 5.10 would be to improve access to naloxone and safe injection equipment, and states can do so through implementing laws and policies that remove barriers to access to naloxone and safe injection equipment. Now I'm going to hand over the mic to Aaron Kesselheim.
Thank you very much. Hi, so my name is Aaron Kesselheim. I'm an associate professor of medicine at Harvard Medical School, and I'm an internist and lawyer, and I run a research group called the Program on Regulation, Therapeutics, and Law at Brigham and Women's Hospital in Boston. And the final part of the report and the presentation today is to try to answer the specific question about what it is that the FDA specifically can do in this area. And I think in general, the guiding principle for the next few slides is going to be thinking about how the FDA can take a public health approach to its oversight and regulation of opioid drug development, approval, and post-marketing surveillance. And I just want to emphasize that this is in distinction to the traditional approach that the FDA takes when it evaluates products in that it usually examines the benefits and risks of the product as they relate to the individual patient that's taking it. And they look at what the efficacy of the drug appears to be and the reports of side effects on that individual. But the particular characteristics of opioids, we believe, requires a certain amount of what we term opioid exceptionalism from the regulator in terms of trying to consider the larger societal effects of the approval and use of opioid medication. And so in addition to emphasizing how this perspective is a distinction from the traditional approach the FDA takes, we also want to emphasize that we believe that the FDA has the authority to use this approach under its current laws and regulations. And in fact, there are particular examples we can point to, and we do point to in the report from other fields in which there are suggestions and hints that the FDA has taken this approach. And what our description of the responses in this part of the book is how this approach can be institutionalized in the case of opioids, and then how it can be implemented. So that's generally just sort of an overview of the committee's recommendations in this section of the book. So this is just a schematic that presents a brief overview of the FDA approval process, just to orient people to some of the upcoming discussions. That drugs usually start with preclinical studies, clinical testing, then there's the review stage, approval, and post-marketing surveillance, which might include risk evaluation mitigation strategies for drugs with particular safety issues, post-marketing requirements or PMRs or commitments to do additional research and oversight as necessary. So we believe that this public health approach is both reasonable for the FDA, given the fact that it is primarily a public health agency, and can be implemented at all different levels of the development process. And that begins with the pre-approval testing period in trying to make sure that when there are new opioid products being tested, new opioid formulations being tested, that there are that we ensure that that testing be done to include at-risk populations, to include potential areas where, geographic areas where we might have increased concern about use of opioids. Again, the traditional manner is to try that pharmaceutical companies take on is to try to create a very small, highly selected population in these trials and evaluate them on the basis of short-term pain score outcomes. And we believe that a broader approach, both in the recruitment of people into these trials as well as the outcomes that are evaluated both in an individual and thinking about a larger community and family level is necessary. So then when we get to the approval process, this is the current schematic that the FDA uses as it thinks about approving products. And as you can see, it's limited to the benefit and risk of the particular product. And then, the FDA will fill in these boxes with the evidence and uncertainties and their conclusions and reasoning around each of them. And so we believe that this current model can be expanded for opioids to try to account for all of the various factors that my colleagues have discussed over the past half hour and that are detailed in the report that might go into the decision about the approval of a new opioid or new opioid formulation that might include the characteristics of the opioid, the benefits observed in the clinical trials both to patients and to the public health, the risks observed to patients and public health, diversion potential, et cetera. And if, again, at this point, if it turns out that one of these boxes is empty because there are no data to collect it, I think that would be very instructive and should then force reconsideration of why it is that box is empty, what information we need to know, how to best collect that information at that point, or how to best collect that information going forward. So this can not only help frame the review and collection of the data thus far, but can help set a game plan for what additional data need to be collected in the post-approval period. So then getting to the post-approval monitoring period, there are a number of strategies that the FDA can use to try to help provide greater clarity about the real-world use of opioids and their effectiveness as compared to the efficacy that they demonstrate in the clinical trial, the risks and both expected and unexpected risks. Those can include these risk evaluation mitigation strategies, changes to the labeling. But again, the committee believes that any of these post-approval strategies, if they're relied on, need to be evidence-based, and there needs to be actual evidence that if a REMS is being relied on to try to help ensure that the drug is being safely used, that there actually is evidence that the REMS is going to do that, and that there is follow-up to make sure that the particular REMS or whatever strategy is being employed is actually having the impact that we expect it to have. Similarly, we would recommend that when new opioid formulations and drugs are approved, that they are formally reevaluated at a certain intervals after approval, so that it is ensured that the post-approval studies, any post-approval studies that are recommended, unfortunately, in many cases, the data that are recommended be collected in post-approval studies are often delayed or not collected by the companies that develop these drugs. But we recommend that the FDA make sure that these things are collected and submitted and formally evaluated at particular intervals. That the FDA reconsider its rules about the promotion and advertising of these products. Given the substantial public health consequences we've seen from overuse of these products, making sure that again, it might be that there are different rules that can help ensure that information is accurately promoted as applied to opioids versus other products. and that the FDA also undertake active post-approval monitoring and not just rely on receiving of voluntary adverse event reporting, but to sort of formally and actively and proactively monitor use of opioids. And then our final recommendation is that it would be we don't think that it's reasonable to just implement these changes for new versions and new products, given the fact that the vast amount of opioids that are being used in the market are some of these products that have been on the market for decades. But we suggest that once these strategies have been developed and implemented, that the FDA go back and formally re-review all of the opioids that are currently on the market to see if they meet these standards and determine whether or not additional strategies particular to certain opioids have to be implemented, or even whether or not there are certain opioids that don't meet these standards and need to be withdrawn from the market. So we recommend a full re-review of all currently approved opioids over the next few years to ensure that people have the pain medication that they need, but that the correct opioids, the opioids are out there are meeting these kinds of public health standards. So this is a broad overview of some of the recommendations made in this final chapter. Again, the big one is number 1, incorporating public health considerations into opioid-related regulatory decisions, and then numbers 2 through 7 go through this process chronologically, as I just described, about how these public health considerations are incorporated into each of the different steps of the review process. And thank you very much. I will turn it back to Richard or...
Hi, Jennifer. Yeah, Jennifer Walsh. So I just wanted to remind everybody, because I know some folks joined late, that this link up here, nationalacademies.org/opioid study, that's where you can download a copy of the report. You can get today's slides on that link. We also have some very useful resources, such as a reports highlights brochure and a brochure just on our recommendations from the report. So please check out that link. So now we'll turn it over to some questions, and we've already been getting some in. So the first question I am going to throw out to the committee is, did the committee determine any way in which we should educate physicians and the public? Is there a belief that one method may be more efficient than another?
All right. Mark?
Yeah, so this is Mark Schumacher from the University of California, San Francisco. The methodologies of education, although many, in terms of how it focuses on education for opioid prescribing and pain management, one, I believe, a successful model has been adopted as somewhat of a trial basis is through the NIH Centers of Excellence in Pain Education, which was launched some years ago, and which are developing modules that tackle real-world problems for complex patient scenarios, with the intent that it provides not only practical skills in terms of guiding healthcare workers, especially physicians, but also provides alongside in-depth evidence-based information to further foundation for those learners. Education, though, is required both at the level of the undergraduate as well as the postgraduate, where these modules under the development are intended more for the postgraduate phase.
Okay. Our next question is, does the committee have any specific plans to improve publicly available data on opioid use?
Tracy?
Sure. This is Tracy Green from Boston University Boston Medical Center in Brown. The report does indeed include some specific suggestions on data and surveillance that would be needed, and that can be found in Chapter 4. But in particular, we've discussed quite a lot about the capacity and capabilities of our country's emergency departments, the medical examiners, and a location that has also been where surveillance of active drug users and people who may come and be institutions that may come into contact with active drug users, and that would be in the jail and arrestee environment. And in each of these are good examples of places where we could learn a lot more, especially now with our electronic medical records, the capacity to collect biological samples, and to test those to let us understand a little bit more about what people have been exposed to, what they're using, and then to ask behavioral, to incorporate behavioral surveillance in those environments to understand a lot more about how people are using medications, medically, non-medically, as well as the drugs and other drugs they've been used or exposed to. And there are also maybe proxy measures like naloxone administration or the number of naloxone administrations, as well as simple service and product acquisition data such as syringe sales or purchases of syringes from pharmacies, all of which may give us clues about the impacts of our efforts as well as problems that are occurring at a geographic and timely specific level. Really thinking about the need to invest in data, much like other epidemics we have met in the past, HIV. From there, we've learned that talking with people who are most affected can give us insight into ways to prevent and how to measure our responses through behavioral surveillance, biological sample surveillance, and then focusing on those vulnerable populations affected by the disease.
Okay, thank you. Our next question. Historically, opioid manufacturers have been very involved in education of physicians and healthcare workers. Do you think this should continue going forward?
This is Aaron, and yeah, I think that this is a very thoughtful question from somebody who obviously knows their history, and you know, I think that the committee did review as during the course of developing the book, did review some of the historical contributors to the current situation, and overzealous promotion and the financial relationships between the pharmaceutical manufacturers of opioids and physicians through the 80s and 90s. In 2000s, I think is clearly at this point determined. It has been shown to be a contributor to over-prescribing in this area. So yeah, I mean, I think that as we were envisioning our recommendations, I think that it would be optimal if the additional any additional educational programs that we envision would be independent from manufacturers. And any educational programs that that might be envisioned for the public would similarly be independent, and I think that would be the optimal way to ensure that the proper communication about the benefits and risks of opioids can be done. There's a number of ways that can be done. There's a practice of academic detailing, which is a practice of independent expert provision of education, through, to physicians, is, sort of a lot of evidence that works to help, appropriately educate physicians. And so, anyway, I think that there are a lot of strategies one can think about of that, but I do think that I personally, speaking here just for me, I do think that the questioner is right, that we need to think about ways of making sure that the educational practices are done independent of manufacturers.
This is Richard Bonney. I'll just add a couple of words to that. There are a number of recommendations in the report that are meant to be starting conversations and further inquiries that need to be undertaken. Some things I think are very action specific and could be implemented if people agreed with them without further deliberation. I think you've heard, particularly in talking about education, physician-provider education, and also about public education, patient education, that it probably is the case that in order to follow up the recommendations that we've made here, that there would have to be some multi-stakeholder colloquia that are established, and in this particular context, to engage the industry to the extent that they would be willing to do so in a cross-stakeholder discussion. of the nature of the problem and the nature of potential solutions to it, apart from issues about responsibility in the past, but really trying to find a way forward with regard to this, because certainly in the committee's view, this is really a core issue to be thought about going forward. With regard to public education, we can imagine that basically assembling at some point in that effort communications experts to think about and formulate appropriate messages that might actually work in this particular context, and that's why we suggested that this would be something that the public health leadership of the country, as well as foundations, might work together on, because this is also not something that's going to happen overnight either. So I would put that particular exchange with regard to the industry's role in that larger context.
Okay, thank you. Our next question, are there specific recommendations of the committee of how naloxone can be made available to those with the potential to use them with the most benefit, given that drugs are highly regulated and their production and supply requires years of planning and production?
So we have a couple, this is Tracy Green, in a couple places in the report we directly address the contribution that naloxone access has made, and in the many hands who can come to an overdose and respond with naloxone include those of people who are laypersons, active drug users and their family members and friends, as well as first responders, law enforcement, and EMS professionals, emergency medical service providers, who currently have good access to naloxone. There are numerous other strategies that we do talk about in the report, especially pharmacy and prescription-based models that are currently available and expanding, and other ways to access naloxone would be critically addressed by reducing the cost of the medication. And that's something that we talk about both as a case example as well as a recommendation to reduce the cost and access, improve access to naloxone in the communities.
Our next question is a question about one of the bullet points in the presentation that says, despite these advances, little is known about why individuals who use prescribed opioids to alleviate pain develop opioid dependence or OUD. The person asked, this statement implies that opioid dependence is different. How so?
So the overall issue, this is David Clark, by the way, the overall issue that we're trying to address is our lack of knowledge specifically of how opioids, when used in patients who suffer from pain, may or may not be different from those who initially use the drugs for recreational purposes and eventually develop an opiate use disorder. There's an evolving understanding at the neurobiological level of interactions between the pain circuitry in the brain and that circuitry that responds to opioids. And we feel that it is a worthwhile scientific endeavor and one that should be supported through granting agencies to better understand what those interactions are, as it might both tell us something very basic about opiate use disorders and pain mechanisms in general, and perhaps offer us an opportunity to better predict who might develop an opiate use disorder or what factors might be protective.
Okay, our next question, given the rapidly rising rates of opioid overdoses in women, did the report highlight any urgent issues that have emerged with respect to pain management for women?
This is Mark Schumacher. We did not, as a committee, necessarily focus on a major effort to drill down to that level. We looked at the overall landscape of the effects. I don't know if we have the data actually that would help us direct to that. I don't know, Tracy, what's do you have a thought on that?
The report does address trends in gender-based access to pain medication, and then in opioid use disorder and the treatment of opioid use disorder in women, and the specific focus on pregnant and postpartum women's access to, and of course neonatal absence syndrome as one of the public health consequences that we are addressing, are also addressed. But with respect to pain management.
Right, and so just if it's just specifically questioned there, there's certainly been research on differences in gender, differences in response to analgesic therapies, for example, and preponderance to various chronic painful conditions that drive chronic pain states, for example, fibromyalgia, for example.
This is David Clark. I'd add the comment that one of the points that we recognized was that there might be a role for precision medicine overall as a concept in better selecting candidates for particular therapies. Sex and gender are factors that might be considered along with numerous others. Therefore, it would be consistent with our research priorities that sex and gender be included in the evaluations that we've gone through and the recommendations.
And that brings us to the top of the hour. We had enough questions to actually continue this discussion for a few more hours, but I'd like to turn it back over to Dr. Bonney for some closing remarks.
Thank you, and again, thanks to the committee and to all of you that have joined us here for this session today. I just want to take a couple of minutes to return to the themes that Dr. Zhao mentioned at the outset. The opioid epidemic is a very serious epidemic. The numbers are extraordinary, and unfortunately, it's still getting worse. Responding to it requires a comprehensive, coordinated, and sustained effort in all hands on deck, including relevant stakeholders in the private sector and in the public sector, including the professions, healthcare organizations, providers, payers, state and local agencies, federal agencies, of course, including FDA, CDC, and NIH, whom we specifically addressed in a various array of recommendations here. This is not to say, of course, that nothing is being done in all of these areas, but the epidemic itself and its magnitude really warrants the effort, and it warrants intensifying the effort across the board. I mentioned it needs to be a sustained effort. We need to sustain the attention. We have a habit in our country in taking notice of certain problems as people are taking notice of this one and then moving on rapidly to something else. We have to sustain the effort and invest in it. It took 2 decades for this epidemic to reach its current proportions, and it will take some significant period of time for it to unwind. So I think it's important to keep that in mind. We've made a lot of recommendations here. I won't try to summarize them now, but I think follow-up to this effort it would be helpful, as I suggested earlier, to see this as an all-hands-on-deck effort where efforts are made by the leadership of public health leadership of this country to facilitate that kind of common effort.
Okay, thank you, and that concludes today's webinar. Thank you again for joining, and please check out our resources on the website.